Today, we are delighted to have two genetic counselors as speakers for our Kelly Echo series. Uh, they will tag team. The first one is Erin Carter. Erin Carter is a genetic counselor at the Catherine O. and Alan C. Greenberg Center for Skeletal Dysplasia at the Hospital for Special Surgery in New York. Erin is a genetic counselor who provides care for individuals all the way from birth to their older ages. She works alongside Dr. Kathy Raju and provides multidisciplinary care to children and adults with skeletal dysplasia. But as though that is not enough, just to reiterate, Erin is truly a bonehead. What I mean to say by that is that she worked in a developmental biology lab before she became a genetic counselor, and she studied proteins involved in shaping and patterning of skeleton. She will tag team with Darwin Argueta, genetic counselor at Baylor College of Medicine within the Adult Genetic Services. Darwin provides care to both for adults with a variety of genetic disorders, including individuals with OI. Erin and Darwin, thank you so much for giving this lecture to all of us, and the floor is yours.
Thank you for the introduction, Dr. Nagamani. I'm going to try to share my PowerPoint now. Share. You can see the slides.
Yep, but you're not in presenter mode.
You can see them in slideshow.
There you go.
Aha. Do they go back and forth? They do. Thank you. I'm going to start us off by covering some of the genetic and phenotypic aspects of osteogenesis imperfecta, advances made and approaches to genetic characterization, hopefully underscoring the evolution, but also the importance of molecular diagnosis. And then, as Dr. Nagamani said, I'll pass the torch to Darwin, who's going to cover some of the practical aspects of testing, including pre and post-test counseling, lab selection, sample collection, and beyond. And then we'll enjoy some cases, which is always a lot of fun on these sessions. We have no financial disclosures. Osteogenesis imperfecta, or OI, has been part of human history since the beginning. There are 3,000-year-old mummies believed to have had OI. It's been described disputably in a Viking warrior, Ivar the Boneless Ragnarsson. In 1678, it was the philosopher Nicholas de Malebranche who gave us the first written description of abnormal bone brittleness and multiple fractures in his book entitled The Search After Truth. I love that. And then in the 1840s, it was Dutch anatomist Willem Vrolijk who coined the name osteogenesis imperfecta, and which we still use today. OI is one of the most common skeletal dysplasias, with a reported incidence of about 1 out of 10,000 to 15,000. And though the exact prevalence of OI is unknown, the OI Foundation estimates that a minimum of 20,000 to upwards of 50,000 people are living with OI in the United States of America. Though there is marked clinical variability, the hallmark clinical feature uniting all types of OI is really brittle bones with a tendency to fracture. Bowing of the long bones can be seen, in some cases detectable on prenatal sonogram in the 2nd or 3rd trimester. There can be scoliosis and extraskeletal features, including dentinogenesis imperfecta, hearing loss, which happens at an earlier age in many types of OI than in the general population, cardiopulmonary problems, muscle weakness, and pain. OI may be first apparent from early in pregnancy to later in life, reflecting the extent of bone deformity and fracture predisposition at different stages of development or postnatal ages. OI is a clinically heterogeneous disorder across the lifespan. In children, this slide shows radiographs or x-rays, of children who are classified as having 3 different clinical types of OI, the so-called mild, this keeps going on its own, the so-called mild type 1 on the left with relatively straight bones and a fibula fracture. There is the perinatally lethal type 2 OI in the center. We can see fractures throughout the skeleton, ribs, long bones. The ribs are short, and there's sort of the classic concertina appearance to the long bones. And then on the right, we have someone who has leg x-rays with type 3 OI, whose tibias are bowed. There's at least 1 fracture, and we see decreased bone density. This is a popular image from Reeder and Orwell's 2006 paper in the New England Journal of Medicine, which shows some of the variability characteristic of adults with mild, moderate, and severe types of OI. All the way on the left, there's a 38-year-old woman with the so-called mild type 1 OI. She's approximately 5'7" tall, so average statured without apparent curvature in her spine or the long bones. In the center, there's a 35-year-old woman with the so-called moderate type 4 OI. She's about 4 feet tall, and we can see some scoliosis and also, I think, intramedullary rods in all 4 segments of her legs. And then on the far right, we have a man who's 40 years old with type 3 OI, who is less than 3 feet tall, and there's definitely scoliosis, curve to the long bones, and maybe some hardware in his arm. Clinical diagnosis of OI is based on an expert review of the clinical and the radiographic findings. And regardless of the time at which an OI diagnosis is suspected, the first line of evaluation needs to include a detailed medical history. A 3-generation family tree should be collected, and we're going to talk about that today, specifically asking about anyone with features of OI, including fractures, osteoporosis, scoliosis, hearing loss, dental issues. Physicians perform a physical examination reviewing all systems. Imaging studies can include the DEXA scan, which is a type of bone mineral density test, and radiographs or x-rays, as we saw, also typically reveals low bone density and may document fractures, bowing of the long bones, scoliosis, and maybe even islands of bone in the skull in some individuals, which are called Wormian bones. Routine metabolic laboratory testing can help rule out other diagnoses, such as rickets or hypophosphatasia, and also can be used to monitor bone health over time. But blood tests other than DNA analysis are neither conclusive nor diagnostic for OI. So it's really all of these evaluations plus genetic testing that can help clinicians distinguish among cause for fracture and bone deformity. And today, variant identification really plays a vital role in confirming or even establishing a clinical diagnosis of OI. Type 1 collagen was first linked to osteogenesis imperfecta in the early 1970s, and the first type 1 collagen gene variants were detected in the mid to late 1980s. The majority of OI is caused by autosomal dominant variants in the type 1 collagen genes. A variant or mutation, as we used to say, are the names we use to describe a change in the chemical makeup of a gene. And the type 1 collagen genes, which are sort of pictured here, listed out on this slide, are named col1 alpha 1 and col1 alpha 2, respectively. Col is for collagen, and then A1 or A2 for alpha 1 or alpha 2. The gene products of col1A1 and col1A2 come together in our cells to form the protein called type 1 collagen, which is a 3-stranded, rope-like connective tissue protein that functions really as the major collagen involved in formation of our bones, skin, tendons, and other connective tissues. Type 1 collagen is considered a heterotrimer, hetero meaning different, because it's comprised of both alpha 1 and alpha 2 chains, 2 alpha 1 chains and 1 alpha 2 chain, to be precise. And it's variants in either of these genes that can cause either a decreased production of type 1 collagen in an individual's cells, a decreased quantity, or production of type 1 collagen that has an altered structure, a different quality. And both of these types of variations, quantitative and qualitative, result in the increased fragility of bones and other signs and symptoms seen in people with osteogenesis imperfecta. It's good to set the stage with a reminder of the central dogma of molecular biology over here on the left side of this slide. We have DNA, which is a chemical unit of heredity. It's composed of chemical nucleotides, which we abbreviate in the language of A's, T's, C's, and G's. The DNA is transcribed into message RNA, which is in turn translated into proteins, which are really polypeptide chains of biochemical building blocks called amino acids. The col1A1 and col1A2 genes are large, and hundreds of different variants have been identified. There's a rule of 3 in this story, because in the DNA, all DNA, not just collagen, 3 nucleotides code for 1 amino acid. And in collagen, 3 alpha chains comprise a collagen molecule. And then within the alpha chains themselves, there's a repetitive amino acid sequence that comes in a triplet. Glycine, XY, glycine, XY, where X and Y may be any other amino acid repeated down the alpha chain. Glycine is crucial for formation of the collagen triple helix. It's the smallest amino acid, no side chains, or any charges. Its placement every 3 amino acids down the alpha chain allows the 3 left-handed alpha chains to intertwine and fold into the right-handed triple helix, as pictured here in the center, forming that rope-like type 1 collagen protein. If you see me in person, I demonstrate this by actually winding my arms together, though I have but 2 arms, not 3, and I pretend that my elbows and wrists are the glycine residues, because that's where the bend has to happen for that triple helix to form. I call type 1 collagen a rope-like protein because of the way that the alpha chains coil into collagen molecules and are in turn packaged into microfibrils and then fibrils that go forth and do the structural work in the bones and connective tissues. In fact, bone is constructed much like reinforced concrete, where an internal cage of steel reinforcing bars is embedded. That's rebar, like pictured here on the right side of this slide. Collagen fibrils are essentially the rebar of our bone, something that I've learned from my orthopedic surgery colleagues here at the hospital. It makes sense that if you have a variant in one of these genes leading to a difference in the amount or the quality of the type 1 collagen protein, that in turn is reflected in how the bones and connective tissues function structurally. Protein testing was available by the end of the 1970s, and for many years, this biochemical collagen screening was performed on cultured skin fibroblasts postnatally. I've collected usually from a 3mm skin punch biopsy, as pictured here on the left, or through chorionic villus sampling in the prenatal setting. Flasks of cultured cells would be shipped off, usually to the Collagen Diagnostic Laboratory at the University of Washington in Seattle, for analysis of the procollagens, like so. The test was used to provide guidance as to whether a patient's fibroblasts generated a decreased amount of type 1 procollagen with normal electrophoretic mobility through the gel. This is the usual story in someone with type 1 OI. Or if the quality of type 1 collagen was changed, leading to phenotypes ranging from a perinatally lethal type 2, severe type 3, or moderate type 4 OI, or if cells produced a normal amount of type 1 collagen with electrophoretic mobility and band sizes the same as what you would see in control cells. In this picture on the right, there are examples of how 3 different qualitative gene variants resulting in glycine substituted by serine might have looked on an SD-urea page gel. After translation, the pro-alpha-1 and alpha-2 chains are processed in the rough endoplasmic reticulum, and the alpha chains have to align in order to start that folding process of the triple helix from the C terminus to the N terminus. During that folding process, there's a normal amount of post-translational modification by specific proteins that takes place, hydroxylating the lysine amino acid residues and the proline amino acid residues that are downstream in the alpha chains. And typically in this process, about 50% of the prolines and 25% of the lysines are hydroxylated or modified in this way. But for alpha chains with an OI causing glycine variant, the nascent strands that are sort of waiting for their turn to be folded into that type 1 collagen triple helix continue to undergo modification while folding is stalled. This delayed winding or folding results in an over-modified type 1 collagen molecule and altered quality, which is bulkier and therefore travels more slowly through the gel. This protein testing detected some procollagen variation in approximately 87% of people who had clinical findings of OI, and clinicians worked with colleagues at the lab to understand how the test findings related to our patients' clinical findings and presentation. I understand there really was an art to reading these gels, and the clinician laboratory connection was important. As technologies evolved, DNA sequencing emerged, and it became apparent that different types of variants could result in these over-modified, slower-moving procollagens on the biochemical collagen screening test. And while other quantitative variants also could result in the decreased amount of procollagen seen in the gel for those with a type 1 OI presentation. Today, variant identification is the preferred method of testing, with DNA sequence analysis detecting a causative variant or variants in over 95% of people with OI. Variant identification is an important tool for accurate diagnosis, accurate genetic counseling, and may even help direct treatment and management decisions. Some clinical trials also may require a documented OI causing variant to see if people have inclusion criteria for participation. Dominant OI variants can run in families or be the result of a fresh change in the DNA, sometimes called de novo. And it's also known that germline and/or somatic mosaicism may occur, and that's usually identified in families where neither parent has any clinical findings of OI, but has more than one child with features of OI. And that's explained by one of the parents having two different cell types in their body, some cells that have an OI causing variant and some cells that don't. And when there are some cells with a variant in the cells of reproduction, the eggs or the sperm, there's a chance for more than one child to have OI, even though the parents are mosaic and themselves don't have any findings of OI. If a genetic marker is established on DNA testing, familial testing can be offered. We can identify parental mosaicism if that's a question, and the ability to offer prenatal diagnosis and even pre-implantation diagnosis is available. Genetic information about different causes of OI and related disorders of bone fragility has increased at least tenfold. We have gone from 2 genes, COL1A1 and 1A2, to more than 20. In the beginning, the technology was Sanger sequencing, going gene by gene, exon by exon, looking for these variants. The first recessive gene variant related to OI was identified in the early aughts, and since 2006, there has been a veritable explosion of genetic discovery. By the 2010s, next-gen sequencing and genomic sequencing technology and massively parallel sequencing techniques enabled the identification of many genes associated with OI and other bone fragility disorders. As of today, the group of bone fragility disorders are caused by a list of mostly recessive, but also some dominant and other X-linked variants and many other genes. This list I've color-coded by inheritance pattern. You can see the gene names that I left in black have multiple inheritance patterns depending on what the specific variant is doing. And I really patched this list of 41 genes together, looking at a variety of reference testing lab panels, bone fragility testing panels, and also consulting the current skeletal dysplasia nosologies group 26, which is where OI and bone fragility disorders live. Given all of these genomic advances, a common question I hear is whether or not genetic testing can tell what type of OI a person has. And also, what type of OI do I have in 2025? In 1979, Dr. David Salentz and co-authors categorized individuals with so-called mild OI as having type 1, infants with lethal OI as type 2, severe OI as type 3, and moderate as type 4. The ability to detect type 1 collagen gene variants revealed a strong trend in the type of variant a person has and their clinical features, that is, classification as 1, 2, 3, or 4. And this is still the most widely accepted classification. It was updated in 2014 to be 4 types plus 1, the dominant type 5 OI due to IFITM5 or Brill variants. And though this is still a very prognostically useful classification, there's a lot of genetic heterogeneity within each of these types at this point. Some people like a genetic classification where the numbering sequence continues up through each new gene. If you look into online Mendelian inheritance in man, for example, the OI type goes up into the 20s. And then there's still others look at the function of the associated genes. There are many genes with various roles in modifying collagen structure or processing, modification, folding, and cross-linking of collagen, primary ossification or mineralization problems, osteoblast development, and so forth. I do think back to the title of Malebranche's book, The Search After Truth, where we had that first written description of brittle bones. I think that advances in biochemical, molecular, and medical genetics has been really exciting in the last 20 years. And it will continue to lead to new insights into the pathogenesis of OI and even other skeletal dysplasias, hopefully leading to improved treatments and interventions for individuals and families that we care for with these diagnoses. And so now that I've laid some of this groundwork, I'm going to pass the torch to Darwin as promised. Darwin, do you want to share yours? Oh, there we go. You want to share your slides?
Yes, of course.
Okay, I think it'll kick mine off.
Okay, thank you so much, Erin. Give me one quick second while I share, and hopefully this is in the correct view.
You're good.
Okay, thank you so much. So for the genetic evaluation of skeletal dysplasias, including OI, there are key components that are needed, such as taking a detailed medical history, family history, physical examination, certain diagnostic evaluations, and of course, genetic testing. For the next part of my talk, I'll mainly focus on the family history and genetic testing aspects. So when taking a family history, it's important to take at least a 3-generation pedigree. And a pedigree can not only illustrate the mode of inheritance of a disease, but it can also uncover other heritable diseases, such as cancer predisposition syndromes that may be otherwise be missed during routine clinical practice. And then here, the squares represent biological males, the circle represent biological females, and the lines represent the relationships between them. And this is an example of autosomal dominant inheritance for OI type 1. And that is evident because we see multiple individuals across generations that have OI type 1. And the likelihood of recurrence for autosomal dominant conditions is 50%. However, I do want to draw your attention here because there are certain scenarios where there is a sporadic or de novo pathogenic variant in an individual that is causing disease, in this case OI type 3, and there's nobody else in the family that has that respective condition. And I wanted to mention this because for the more severe forms of OI, these types of pedigrees can be typical. And this is a 12-year-old girl who has OI type 3. And for my last example for the family history, I want to show one that shows autosomal recessive inheritance. Here we see a 10-year-old girl who has OI type 11 due to pathogenic variants in the FKBP10 gene. And she inherited one pathogenic variant from her mom and one from her dad, which would make them carriers for this condition. And when carriers have children, there's a 25% chance for each pregnancy or child to have the exact same condition. And I do want to point out that in this example, there are multiple individuals with OI within the same generation, but not across generations. So that is one distinction. So now that you have a better understanding, thanks to Erin, about how patients are evaluated and how to analyze a pedigree, I do want to mention some practical aspects of genetic testing and counseling, specifically discussing the types of genetic tests that are available and which one would be most appropriate for a patient, what laboratories offer that particular test, and then also the importance of pre-test counseling and the samples that you'll need to undergo clinical genetic testing, and what goes into a results disclosure as well. So although there are different types of genetic testing, for the purposes of this talk, I have categorized them into two broad categories: cytogenetic testing and DNA sequencing. For cytogenetic testing, you can have carrier typing, which is a picture of chromosomes that can detect extra or missing chromosomes or structural rearrangements and can diagnose certain conditions like Down syndrome, Klinefelter syndrome. You could also have chromosomal microarray, which can detect extra or missing chromosomes, and as well as submicroscopic chromosomal changes. For DNA sequencing, you could have Sanger sequencing, which can be used to interrogate one or a few genes. You could have massively parallel sequencing, which can interrogate multiple genes that are associated with a phenotype like cardiovascular disease, skeletal dysplasia, and of course, OI. Exome sequencing, genome sequencing, these are DNA sequencing technologies that are more genome-wide screening tools and that are often used for individuals that have a more complex phenotype or have multi-system disorders. So now that you're aware of the genetic testing technologies, how do you find the appropriate tests for your patients? So there are many resources available, and here I illustrate two. I illustrate the genetic testing registry, which you can use to look for genetic tests or just see what genetic tests are available for certain indications. Concert Genetics allows you not only to search for certain genetic tests, but also to compare the gene content from different panels from either the same lab or from different laboratories. And if you were to do a search for the term osteogenesis imperfecta, it is more than likely that you'll come across different panels from different laboratories, such as the one shown here. And in this illustration, which it is by no means a comprehensive illustration of the different genetic testing options that are available, I simply want to show you 6 different genetic testing laboratories and the different genetic testing options that they offer. So you'll see, going from left to right, that genetic testing laboratories can offer small or limited panels, which interrogate a few genes. They could offer expanded panels, which interrogate multiple genes, all the way to exome and genome sequencing. Okay. So once you know the genetic test that you want to order and know what laboratory you want to get it from, there's different ways that you can order the respective genetic tests. One of the more common ways is to do it directly through a genetic testing laboratory's portal. This will require creating an account, but once that is done, it is fairly easy to input the information so that you can successfully place your order. And some of you may have the privilege of doing an EMR integrated order where you could simply do the genetic tests through the EMR, which can make the process that much more easier or smoother and can be very convenient if you're somebody who orders genetic tests somewhat often. And also, it's important to know what samples you would need from a patient so that they could do their clinical genetic testing. One of the samples that you could use is a buccal or cheek swab sample, and you just simply take a Q-tip and swab the inside of the patient's cheeks for about 30 to 40 seconds, invert it back into the liquid solution that you see here. You could also take a saliva sample, which requires a patient to essentially provide their saliva spit into a tube and make sure that it's up to the fill line. Both of these require that the patients not eat or drink anything 30 or 40 minutes prior to providing their sample. And then, of course, you could also get a blood sample. It just requires the phlebotomy team to get 3 to 5 milliliters of blood and to put it into an EDTA tube. So now that you know more about the practical aspects of genetic testing, I do want to shed some light on the counseling that we give our patients. So it's important to inform patients what the genetic tests can tell us. It's important to mention that this can confirm or rule out a diagnosis. And once the causal variant is identified, it can confirm the mode of transmission and the likelihood of recurrence. And as Erin was suggesting, certain variants can potentially inform the clinical course and severity, although in OI, typically the clinical presentation is sufficient. And also, as Erin mentioned, when you know the specific variant that is involved, this could open the doors for certain clinical treatments or clinical trial opportunities. I do want to discuss the Genetic Information Non-Discrimination Act, or GINA, briefly, because it is an important topic for certain OI-related indications, but not necessarily for all of them. But in a nutshell, GINA is a law that protects individuals from being discriminated against from their employers and health insurance based on their genetic information. Limitations include that it does not give you the same protections from life insurance companies, disability insurance or life insurance or long-term care insurance. And as part of the pretest counseling, it's also important to dispel any myths or misconceptions people may have about a particular disorder. And also, patients may share feelings of guilt, which would be important to address. And to set expectations, it's also important to discuss the types of results that you can get with genetic testing, which includes a positive, negative, or a variant of uncertain significance. A positive result means that a disease-causing or pathogenic variant has been identified in a gene. And when that happens, it's important to understand what that gene is associated with and whether the patient's clinical presentation or phenotype matches it. And also if the mode of inheritance matches what you see in the family history. A negative result means that no pathogenic variants were identified, and for certain indications, this might warrant exploring other testing approaches with genome sequencing or exome sequencing if not performed already. And a variant of uncertain significance, or VUS, is an inconclusive result. That means we don't have enough evidence to say whether that particular variant is a positive result or a negative result. There are certain things that can be done to try to determine whether that variant is leaning more towards likely pathogenic or likely benign, including family studies, research testing, and functional analysis. And since a VUS can sometimes be considered a non-diagnostic genetic test result, it might be worthwhile to explore other testing approaches if it's warranted as well. So there is a 5-tier variant classification system, as I was kind of alluding to before, and I simply want to mention some of the factors that are taken into account to make these interpretations about these variants. And things that are taken into account include population frequency, computation and predictive data, knowing how a specific variant can affect the protein function, functional data is also important, segregation data, knowing whether a variant of interest is seen in individuals with disease, or if it's seen in individuals that don't have the disease, and de novo data. So all of these are taken into account to make these interpretations. So a likely benign and benign variant, this is a negative result. These are typically not reported in genetic test reports. A VUS is an inconclusive result, and of course a likely pathogenic variant is a positive result. So now that you know more about the types of results that you can get and how to potentially interpret a genetic test report, it's also important to know what goes into a results disclosure. And of course, this is highly dependent on the type of genetic test that was ordered and the result that you get back. For a positive result, you could get a result that this could be something that was expected or unexpected. And in the case of a negative result, it's important to anticipate patients' questions. Because, for example, if somebody has a clinical diagnosis of OI and has a negative result, the patient might ask, well, what do we do now? Is further genetic testing warranted? Or in the case of somebody who's coming in for a family history of OI and has a negative result, well, are they a true negative? Meaning, is there a known causal variant in the family? And was this individual specifically looking for this causal variant? A VUS result can provide anxiety to patients due to the uncertainty. And as I was alluding to before, there are certain things that we can do or take into account to determine whether we think a VUS is leaning more towards likely pathogenic or likely benign. But oftentimes, that is not very easy to ascertain. Incidental findings are genetic changes that are seen in a patient that would increase their likelihood of developing certain diseases like cancer or cardiovascular disease that is unrelated to the primary reason of why the test was done in the first place. So I wanted to mention this because when you're disclosing results, it's important to give a brief summary of what you're going to tell the patient. And in some instances, it's also important to give a warning shot so that patients can be mentally prepared to receive the information that you're going to give them, because this could cause certain psychosocial concerns for patients. So when you're giving a result disclosure, it's also important to ask the patient how they feel about the results, regardless of what that result is or what the indication was, because sometimes patients may share feelings or thoughts that you wouldn't have known about if you didn't ask. And sometimes feelings of guilt or shame could come up, which are important to address. And you could use positive reframing to address certain psychosocial concerns as well by discussing some of the benefits of knowing that somebody has a genetic diagnosis. Perhaps this could open the door to them being a part of specific support groups or just having access to specific information that is pertinent to them. And of course, we do create family letters, which help patients have conversations with other family members about their condition, and how they could go about doing genetic testing if it's warranted. And oftentimes, adults, when they receive these family letters, they may want to see preconception or prenatal genetics because they may be interested in pre-implantation genetic testing or PGT, or they may want to discuss the likelihood of recurrence for their children or future children. And for a person that is pregnant and has a higher likelihood of having a child with OI, prenatal ultrasounds can be valuable because they could give potentially a prenatal diagnosis before 20 weeks gestation, especially for the life-limiting and severe forms of OI. For the quote unquote mild forms of OI, these could also potentially be detected prenatally, but oftentimes much more later in the pregnancy due to fractures or deformities. And just going back to PGT, which is also known by different names, this does involve the in vitro fertilization process. It involves taking embryo biopsies and genetically testing them to determine whether they have the known causal variant. And the idea is to ascertain which embryos do not have the known causal variant for implantation purposes. So to end this part of the talk, I do want to mention a few appropriate indications when patients can be referred for a genetic evaluation or counseling. And of course, patients who have themselves a skeletal dysplasia that want to seek a genetic confirmation, that would be a good indication for referral. Or also individuals who have had genetic testing and have had some VUSs or inconclusive results, or who have previously received a non-diagnostic genetic test and are now wishing to undergo further genetic evaluation. Of course, people with a family history of skeletal dysplasia can be referred. And for patients who have a skeletal dysplasia, they might be interested in seeing preconception or prenatal genetics. An individual that is pregnant and has a pregnancy with features of a skeletal dysplasia might also benefit from seeing prenatal genetics. And with that, I'll end this part of the talk. Thank you so much for your time.
I wanted to thank Erin as well as Darwin for an excellent genetics talk and practical aspects of genetic evaluation. If you have questions, either type it out in the chat and I can ask, or please unmute yourselves and ask. The speakers would be happy to answer. We have 5 minutes, around about 5 minutes for questions, and after which Dr. Jan, Darwin, and Erin will have a few illustrative vignettes for you to reinforce some of the points they've raised. So, Erin and Darwin, both of y'all what is your approach while picking a test when you clearly see it is an autosomal dominant, most likely type 1 collagen-related OI, COL1A1 and 1A2? Is your preference to just stick to the COL1A1 and A2, or do you go for a broader panel just because of the ease with which you could order this at multiple labs? And how do people who do not do this daily, what would your advice be for them?
Yeah, that's a very good question, Dr. Nagamani. So nowadays with genetic testing, the cost of doing a genetic test for a single or two genes is about the same or the same for testing 60 or 80, 100 genes. So typically in that type of situation, I prefer a panel-based approach that includes obviously COL1A1 and the COL1A2 genes, and as well as many other genes that are known to cause OI. And I go with that approach because I feel that as long as the patients are properly consented about the genetic tests, understand the benefits, the limitations of it, the types of results as we've discussed, it's fine. Sometimes when you take that approach and opt for a much bigger panel because you are essentially casting a wider net and looking at more genes, the likelihood of getting a variant of uncertain significance, a VUS result, increases. So I do mention to patients, if we do, say, a skeletal dysplasia panel that's 300 genes or so, that, we're more than likely going to get an inconclusive result. But that's okay because this is what an inconclusive result means.
We would do the same thing here, typically go for a panel test. Sometimes I encounter, I mean, the insurance piece can also be a factor if trying to obtain pre-authorization for molecular genetic testing. There are some insurance plans that have rules about what tests you can and can't do that dictate strategy somewhat. But yeah, I agree with what Darwin said. And I think the nice thing about being someone who's trained in, both the genetic and the psychosocial side of things is we can really work with people on that pre-test counseling piece so they know what to expect. They feel confident. We happen, of course, to be at, renowned metabolic bone centers, both of us. So they feel confident in the team to help shepherd them through whatever results come back, expected or unexpected.
Erin, before we move to questions, I don't see any questions in the chat, so I'll ask you one practical question you might
We
share.
must have been so clear.
Absolutely.
Crystal.
There you go. So one of the things that most academic centers we think about is when we get a negative genetic testing, and you do think that the phenotype is consistent with a heritable form of skeletal dysplasia or OI, but you do not see a variant. When do you, what factors will make you enter a patient to a research study or undergo a more extensive testing versus saying, we got a negative result, but clinically this is what you have, and we'll treat you as someone who does. So what is your approach to something like that?
This is a process I'm always excited to embark on with a patient and their family if it's something that they are interested in doing. And so sometimes people want to move forward. They would like to try to do some sort of research testing beyond what they've already done. In some cases, I probably phoned many a friend who are on this call right here and right now to say, hey, I have a patient, this is the presentation. Are you working on any genetic studies, trying to, form connections and collaborations to try to understand if we can find an answer for the patients that we get to work with. So if people are disinclined or don't want to move forward with additional testing or research studies, then of course we have to honor that. But I'm a big believer in working with people to try to advance the knowledge, because if we can't advance knowledge, we won't advance care.
Any other questions, or can we go to the vignettes now?
I'll have a question. Hi, Sandesh. It's Roy.
Nice to see you, sir.
Hi, Erin. So how
Roy.
difficult it is to detect mosaicism? So in a collagen 1 mutation, so is it always immediate from the first testing, or you have to do further testing to make sure that, the mutation is just perhaps mosaic?
So usually mosaicism, that like the concept of mosaicism, and I think I said this, we figure out that a parent may have mosaicism for an OI causing variant when they have more than one child with the same thing. And that's not just an OI, that's in any genetic condition that can happen in people. And so then the question really becomes, like how do you test the parents? Because if you do a blood draw, what if the variant isn't in the DNA in the white blood cells? What if it didn't make it into that tissue? And what if you can do a skin biopsy? There have been papers where people went through and studied various specimens that were collected from parents with known mosaicism. I think it came out of Dr. Marini's lab. I can find the article and send it to you later. The rate of mosaicism, I don't think we know. Dr. Nagamani, do you remember that paper? Are you familiar with it? They detected a surprisingly high percentage of mosaicism within a person. And that person themselves did not manifest signs and symptoms to reach a clinical diagnosis of OI. So the human body can withstand quite a bit of variation, and I think there's a lot of redundancies.
And to reinforce what Erin said, Roy, the level of mosaicism that the labs are comfortable in reporting is very lab dependent, and how much coverage they have and what their platform actually is. Most laboratories typically will be able to confidently detect if it is 10% mosaic on the reads, but I'm not sure whether everybody reports that out, if that's what you were asking in the blood.